Cara, I learned so much on this episode because for the first time in my life, I met a pediatric hematologist. And in this case, it's Dr. Kristina Haley.
I mean, they're special people in general, but she's amazing.
We got to go deep on the issue of blood disorders and specifically blood disorders in girls and women and how signs in periods can help us uncover blood disorders. Kristina works closely with the Foundation for Blood Disorders in Girls and Women and is also a pediatric hematologist in Oregon. But the stuff that we talk about is so specialized, but it's not boring. It's so cool. And I had such a blast learning from her.
So Dr. Kristina Haley is a hematologist. So she cares for people with blood disorders, including bleeding and clotting disorders, and is the director of the OHSU Hemostasis and Thrombosis Center. Together with Dr. Maureen Baldwin, Kristina directs, best name ever, Vanessa, the Spots, Dots, and Clots Clinic at OHSU Center for Women's Health, caring for adolescent girls and young women with bleeding and clotting disorders as well. And she does research too. She looks specifically at platelet disorders and talks quite a bit about them on this episode. It's really a wonderful top-line view of how to think about bleeding in kids, teens, and frankly, adults, and how to know when you might want to ask your doctor for a referral to a hematologist.
And watch out for all the puns because there are many.
Vanessa's puns.
Some are on purpose, some aren't. But see if you can keep count of how many blood and period puns there are in this episode. Enjoy. Hi, Kristina.
Hi.
Kristina, we're so excited to have you here. And I want to start with a little story as a way into this conversation. And the story dates back to my days as a college student. I had 4 roommates, and one of them had her wisdom teeth taken out. And when she had her wisdom teeth taken out, we all thought the amount of bleeding that was going on was fine. No one really thought anything about it. And she bled, and she bled, and she bled, and she bled. And then my next memory, I'm going to jump to, was she saw a hematologist, a blood doctor like you. And that hematologist said, this is a really common way people end up in my office because they bleed more than expected. There's no reason for you to know what's more or less, but this is more than what's expected. And my guess is that when you get a cut and it's a bloody cut, you bleed more than other people. And she's like, oh, I never thought about it. And my guess is your periods are pretty heavy. And she's like, yeah, well, I thought that's what everyone's periods were like. And he ended up diagnosing her with a factor deficiency, which you can explain in a minute. But the way she was picked up was not because she was terribly sick. It was because she did something really, really standard and common, which is get her wisdom teeth out. And that was the first sign that maybe her body bleeds more than other bodies. And none of it would have mattered at all, except throughout the next 30 years of her life, she has always told any other doctor that she goes to, I'm a bleeder. It has mattered when she has surgery. It mattered when she had babies. And so the information, while it hasn't impacted her life in any kind of profound way, really matters. And I think that's probably the first place to start this conversation. Is like, can we talk about that? What do you do for a living? And why does it matter if someone knows if they bleed a little bit more or a little bit less than someone else in terms of their lifetime health?
Yeah, it's like a very classic story of somebody's road to being diagnosed with a bleeding disorder. So I'm a pediatric hematologist. So I trained as a pediatrician and then did another training for 3 years in pediatric hematology and oncology. So those two disciplines are connected in medicine. So everybody gets trained in both. But I'm specialized in hematology, and we like to sometimes say classical hematology. So non-malignant blood disorders, things that make you bleed too much, things that make you clot too much. Also could be problems with your hemoglobin, like sickle cell anemia, all sorts of different problems with your blood. And I take care of patients with those types of disorders from birth until early adulthood, maybe, until they're ready to transition to an adult provider.
And Kristina, do you mind if I ask what drew you to that particular field of medicine?
Did you have to use the verb draw with blood? Was that what was happening there?
It was not. It was a subconscious pun.
Well
I love it. I'm all
so
on
does
board.
Cara. She's trained me.
Oh, they're so good.
They're so good.
So when I was in medical school, I spent some time in a rotation in a hospital setting in pediatric hematology, and I did my medical school training in Chicago, and I worked with a few patients with sickle cell disease, and it just was, we were able to look at their blood under the microscope and really like see what the problem was, that their blood cells weren't shaped in the way that could make them easily flow through their blood vessels and could get stopped up. And then just from there, I love kind of connect what I was seeing in the labs to what the patients was experiencing. Hematology is a bit of a puzzle. And it's also kind of, I always think of hematologists of like, we like to sit in our office and like open our textbooks and like really just like pour into like what could be going on. And it's like you sit and think for a long time. We're not like doers as much as we are thinkers. We're like just kind of thinking about things.
You're an investigator.
Yeah. If I wasn't like so scared of all things, I would have been like a police investigator, but like that is very scary. So I would never do that.
Well, I think we're all grateful that you are scared of other things and not scared of looking at blood, and therefore lots of people benefit from that.
I mean, you're downplaying a little bit the incredible sophistication and intelligence required to be a hematologist. Vanessa, there are a few fields where the people who go into those fields, it's like it's just a proxy for wowza about their brain. And hematology and oncology is one of those fields. They're just smarter, frankly, than the rest of us.
Very nice.
That's the club. It's the club I would never be invited into. Do they have a field in medicine for people with really good personalities?
They do. It's called general pediatrics.
Yes, that would be
my field.
Well, luckily you've conferred that degree on me, so I'm all set and I don't even have to go to medical school. Okay. So Kristina, can you just draw the distinction for folks? Because we're going to get into bleeding, we're going to get into periods, and we're going to get into blood disorders, but it's super important that people understand what your field of medicine covers and what it doesn't cover in that context. Can you just give people a little bit of context there?
Yeah, so I work in thinking about, is your heavy menstrual bleeding or is your bleeding symptom due to a problem with how your blood clots? Where maybe if you have, like, let's say you're having really bad nosebleeds, I'll be like, okay, I'm going to do my workup to see, is that due to a blood clotting disorder? And if not, I might send you to an ear, nose, and throat doctor to help manage that. Or if your periods are really heavy, I'm going to do my workup to figure out what's going on there from a blood perspective, but also really important to work hand in hand with a gynecologist or a general pediatrician, a family doctor, somebody who can make sure we're not missing any underlying gynecological or hormonal problem that might be causing periods to be heavy.
Great. So just to remind people, we have an episode with Dr. Hina Talib, who's an adolescent medicine specialist, and we have an episode with Dr. Karen Tang, who's a gynecologic surgeon. Those are the episodes that you go to listen to for specific issues related to periods on the gynecologic side. This is on the blood disorder side. So if you need to press pause and go back and listen to those and come back to this episode, this is your moment.
Now, it might be helpful at this point to walk through the clotting cascade, the pathway about in the most basic way so that people understand the steps involved and why you have to sit at your desk and think for a while about what's causing all this.
Yeah. So when you need to form a clot, you've gotten an injury, your uterine lining is shedding, whatever it might be, the first thing that kind of happens is that the cells that line your blood vessels, those break, and that's what's caused the injury, and blood leaks out. When those cells break, they kind of expose different proteins that sit underneath those cells, and your platelets that are circulating in your blood, they sense that, and they go there and they stick to those proteins. And so that's like the first step. Platelets stick to those proteins, and then the platelets send out a bunch of signals to other platelets to recruit them over and start to form like a plug that stops the bleeding. And then as that's happening, you have a bunch of different clotting proteins that are numbered, and then they get activated in a non-numerical fashion, which is like the bane of every medical student's existence. But
so they're numbered, but they don't work in order of their numbering. Is that right?
Exactly.
Okay.
Yeah.
Just wanted to be clear on the rationale there. Keep going.
Yeah. So they get activated and they form like a glue that seals your clot together. And that glue is called fibrin. And so the fibrin sticks down and holds everything together. Some people think of it as like the platelets are like bricks, and then the fibrin's like mortar that seals it all together. I always mess up. Like, I'm always like, is it brick and mortar? Is that how that works? But cement, I don't know. So anyways, bricks and mortar. And then you have another system in your body called the fibrinolytic system. So fibrin, that glue, and then lytic, breaking apart. And as soon as you form that clot, your body quickly acts to make sure it doesn't extend or cause a big problem and block blood flow. And it allows you to break down the clot and keep it where it is, so then your body can heal that area. And then you're set.
So that sounded really simple, but I just sent Vanessa an image that she can screen share, and we'll link in the show notes, that shows the complicated pathway that you have just described as if it is easy peasy in such a beautiful way. Because you can see with this image, and for those who don't have access to YouTube when they're listening to this, link in the show notes, or you can go online and look up the clotting cascade, and you will see all of the different factors and all of the steps in the pathway where there is room for error, right? So when you're sitting at your desk, Kristina, and you're doing the deep thinking, what you're really doing is trying to figure out where along this series of pathways, it's really not just one pathway, it's multiple pathways converging, where the problem lies. And that is complicated thinking. And can you talk about a couple of the different things that you use in order to figure out why you land in one place over another?
Yeah. So it's very rare to go see a hematologist and not get blood work done. So we have to check your blood to be able to see what's going on inside of it. And so we'll draw some screening labs often to kind of think about, okay, can you go from step 1 to step 6 or whatever it might be, and see, do you make the fibrin? And that will help us kind of eliminate any of certain types of factor deficiency or clotting factor deficiencies. And then we will also standardly do a test looking for a specific bleeding disorder called von Willebrand's disease. And that is just named after Eric von Willebrand, who discovered it a long time ago. And so that protein is a protein that helps your platelets stick to the area that's been injured. And so that is the most common bleeding disorder that we see. And so that's why we will do that lab test up front. And then we might do some tests to look at how your platelets are working, how they're sending those signals back and forth. Platelets, though, are really sensitive to everything. And so a lot of times those tests are kind of our second line tests, because you need to come back to the center, whatever it might be. Also, all of these tests are actually pretty sensitive to how the blood is drawn, how it's collected in the tube, how it's processed at the lab. And so sometimes we can get some false positive. So maybe we get a test that's abnormal, and then when we repeat it, it's actually normal. And so sometimes this is a very iterative process of we like get your history, check some labs, try to repeat some labs, and kind of go back and forth.
And I just want to add that as a pediatric hematologist, you are both completely dependent on these labs in order to make many of your diagnoses, and you have patients who are completely not into giving you their blood, right? This is really a hard piece of this. And then you layer into that sometimes you have to do it again.
Yeah. Yeah. I know it always is like so heartbreaking to me to say, I need you to come back. And I know that was really hard. We are really fortunate here in a lot of children's hospitals too, where the phlebotomists, the people who draw your blood, are particularly trained to help with kids. And we have child life therapists to help with those blood draws and try to make it as best as it can be.
They are amazing. Those pediatric phlebotomists and the ICU nurses who work in the NICU and the PICU, they're incredible at drawing blood. Can we go back to one little comment you made? You talked about von Willebrand's. Can you just share quickly how common it is?
Yeah, von Willebrand's disease, it affects, we think, around 1% to 2% of the population, which is a ton of people. I think it's sometimes, when you say 1% to 2%, you're like, oh, that's like 1% is a very small number. But that's like for a disease to affect that many people is huge. And a lot of people don't realize that they have von Willebrand's disease and might not experience symptoms until their clotting system is kind of challenged. And so sometimes that's the hard part in pediatrics is that you don't have a lot of what we call bleeding challenges. You haven't had surgeries or, maybe not trauma, which is, always good, but we just haven't like tested your bleeding system until maybe you start having periods or something else.
So let's get into, I'm just trying to think. I was about to say, let's get into periods, but I'm like, okay, is there a pun in there that I'm saying that I don't? I guess I could say, let's dive in. I mean, there's nothing good. There's no good pun there. It's all weird and gross. So I'll just stop right there. Kristina, give us a scenario. What is a common scenario in which you will get a tween or teen visitor to your office related to periods and menstruation?
So it might be, there's so many stories. I also love first ever period stories. And so I just try to capture everybody's first ever period and how that went. But
you'll come back and do that episode
you're,
with
you're
us.
Right at home with us on this podcast.
I just love it. And who was there and what slumber party were you at and all those things. So it might be that somebody is maybe 12 years old. They started their period 6 or 8 months ago. And the first one maybe was a little bit long, maybe 8 days. But everybody was like, oh, it's your first period. It's okay. We're going to kind of push through. And then since then, every period has been 8 to 10 days. They're missing school because they can't keep up with changing their pad at school in order to get to class and everything like that. Going through their pads every hour or two and soaking through those pads, maybe waking up in the middle of the night to have to go to the bathroom to change their pad. And it's just constant and feels forever of bleeding.
Mm-hmm.
And then it might be too that what brought them kind of to attention was that they started to develop symptoms of anemia. They were having fatigue or headaches or dizziness. And finally, their parents noticed and they're like, oh, we need to do something about this. But then it's not uncommon while we're talking, they come to our office and we say, okay, tell me about your periods. They're 8 days long. You're changing your pad every hour and a half. They're soaked. And then you say, hey, to their mom, can you tell me about your period? And the mom's like, well, mine are between 8 and 9 days. They've been like that since I started. I've been on different hormonal pills all through my life. And they just have this really similar story. And they're like, this is just normal in our family.
Mm-hmm.
And von Willebrand's disease, that most common bleeding disorder, is inherited in a dominant fashion in most cases. So meaning there will be somebody in your family, one of your parents has this disorder. And so we often diagnose a bleeding disorder in the pediatric patient and then refer the parent to an adult hematologist so that they too can get their diagnosis of von Willebrand's disease or other bleeding disorder.
You're taking this history, you're getting a sense. Are there particular blood disorders that your mind goes to first as like von Willebrand's, or maybe a couple of other ones that you're like, it's probably this and this is why? Or are you like, okay, we know we're in this field for these reasons, but we've got a bunch more investigating to do? Where does your mind go, Kristina?
Since von Willebrand's disease is so common, that's often more like, okay, we at least need to rule that out. And then our ability to diagnose platelet disorders, so how platelets send signals or respond to signals, isn't great. Our testing isn't the best and it's not widely available, but they're really common and have very similar symptoms to von Willebrand's disease. And so there's a big overlap there. So I often will think this might be a platelet disorder. There's also increasing information about how connective tissue disorders like Ehlers-Danlos syndrome, which is a problem with how your collagen is made and makes people like hypermobile or hyperflexible. Patients with that also can have bleeding symptoms. And that is really common as well. Like somewhere, I think around 1% of people also have joint hypermobility. And so those are kind of those most common things that I think of right away.
Let's talk a little bit about bleeding symptoms and what they look like, because sometimes there'll be a kid who scrapes a knee and bleeds for 2 hours. And sometimes there's a kid who has always healed apparently perfectly. And now they're suddenly at a hematologist's office being told you have a problem. Can you help people balance those and give them a sense of what they need to look for at home if they think maybe this is a path I should be going down?
Yeah. I think that nosebleeds are kind of a good spot to think about. Nosebleeds are really common, although there's like people out there who've never had a nosebleed. I'm always like shocked.
Who are they?
I don't know.
Fun.
It's the same people who've never.
They don't live in my house. That's for sure.
Same people who have never had a headache.
I don't understand. So nosebleeds are really common, but if they're lasting a long time, so like 10, 15 minutes, and they're frequent, maybe once a week, a couple of times a week, if they are not without like something that provoked it. So
picking. Nose picking is the number. I'm just going to be the general pediatrician for a second. When you got a finger digging in the nose endlessly, that nose cannot heal. And that's, if there's a scab or a bleed, they're picking that right off. So we got to get the nose pickers off to the side. That's what, like a solid 80%.
Oh yeah.
The population. Yeah.
Totally. Or like you got hit in the face with a soccer ball. Really normal to like bleed after that. But then, or if it's somebody who has a ton of allergies, like things like that, and then you have nosebleeds, that's maybe more typical. But if it's kind of out of the blue, people in your family have nosebleeds. I also always ask about like, how do you manage your nosebleeds? Because some people are like, well, I just lean over the sink and wait for it to stop bleeding. So nosebleeds, you have to apply pressure and keep the pressure there. That helps it clot.
Cara taught me a trick. The key trick. The key trick.
Oh, I don't know the key trick.
The cold key trick. Oh my God, you're going to love this.
Oh my God, Kristina, welcome to our hematology podcast.
I'm so excited. Vanessa, we should do a social media post about this. So in addition to your nice, firm pressure on your nasal bridge with the head either at neutral or ever so slightly cocked back, if you can take a key and put it in the freezer for a couple of minutes, and then you take it out and you put it on the philtrum between the upper lip and the nose, the blood vessels constrict very quickly because of the cold, and boom, there you go. Bye-bye nosebleed.
Okay, I'm going to add that to our instructions for nosebleeds.
I feel very useful in this conversation.
I love it.
Can we talk for a second about ITP and rashes that some adults might not recognize as bleeding, but they're really signs of bleeding?
Yeah. So ITP is immune thrombocytopenia. So thrombocytopenia means low platelets, and then it means that your immune system has attacked your platelets. Usually it's like after an infection, your immune system was like, I'm fighting this virus. And then it was like, oh, wait, these platelets kind of look like that virus. And now I'm going to attack these platelets. And in most pediatric patients, it self-resolves with a few months and goes away. But your platelets can get really low and cause bleeding symptoms. And skin symptoms are not uncommon. And the biggest one is something called petechiae. And petechiae are like little red dots, kind of look like freckles in some way, but they're red, can be purple. And then when you like put your finger on it, it doesn't go away. So you look and see, and it stays there. So petechiae can happen when your platelets are low. They can happen with some other bleeding symptoms or bleeding disorders as well. Sometimes they can be like, some people get them when they like wear their backpack really tight and they like hold on to their, and they're like right on their shoulders, right where the backpack was. That is usually not a sign of a bleeding disorder. And it means you just need less books in your backpack probably. But other times, if you have like recurrent petechiae, especially without trauma, that might be a sign of a bleeding disorder. Bruising is always really hard because it's hard to know what's a normal bruise versus an abnormal bruise, or what's too much bruising. I think about bruises that are raised like a mound rather than flat are usually a sign that maybe you bled a little longer into that area. And so that could be a sign of a bleeding disorder. Bruising with minimal trauma, bruising without that is beyond what you would expect for the trauma is a sign that could be abnormal. Not all bruising is a bleeding disorder, but sometimes it will warrant further evaluation.
So my husband played golf maybe 10 years ago. He was playing golf and he did a particularly enthusiastic swing and he felt a little like twinge, a little pinch. And about an hour later, he called me and he said, can you drive to where I am and meet me where I am? I think I need you to take me to the hospital. And I said, okay. And he had torn a tiny little blood vessel, teeny little blood vessel in the teeny little muscles between his ribs. Oh. And unbeknownst to him, he had ITP, probably from a virus. Oh. And by the time I got there, he had what looked like a second trimester pregnancy coming out of the side of his rib cage. And it was just filling with blood. So it becomes very obvious sometimes. And he had no other signs. But ITP, one of the reasons it's so important for us to talk about it is some people who get ITP get it because they have chronic issues that make them more likely to get it. And some people get it because they've just had an infection and their immune system is overly enthusiastic. And regardless of why you get it, you can actually have a little bit of this internal bleeding. And it is absolutely, if you're listening to this podcast and you're thinking, I would never take my child to a doctor that's just going to draw blood in order to make a diagnosis if the kid is fine and what do I need to worry about it? Like, actually, this is one where if you do suspect internal bleeding, we got to fight the kids on drawing the blood and we got to figure it out because the same kid can then run out on a soccer field and get a concussion. And when you have a bleeding disorder that can cause significant internal bleeding, and in ITP, your platelets don't work, right? So you can bleed a lot. Then you can end up getting some very serious consequences if you hit your head or if there's sort of a whole path that we can go down. So I don't want to be a catastrophizer, but what we're talking about in terms of bleeding disorders is one to not blow off. It's one, if you have a question about it, you call your doctor. It's not one to just look up on Google and reassure yourself. It's also not one to freak out about.
Totally. Yeah. Right? Yeah.
So if we think about that sort of philosophy in the context of periods, and we think about the fact that kids' periods don't regulate. I mean, we typically say 2 years, but now there's new data that it's taking longer for periods to regulate. And in the modern day of earlier puberty and all sorts of earlier menstruation. So how the hell do we know if we should be concerned if it's irregular because it's just they're not, at the stage yet? Like, You talked a little bit about the amount of blood, the duration, but talk us through with more specificity, Kristina, like when do we listen to Cara's advice and not blow it off and go see someone?
Yeah. So I think from a period perspective, even in the beginning of period life, bleeding longer than 7 days is too long. And then simultaneously, if you're changing your products more than every 2 hours, sometimes this is always like you have to ask all the questions about how often do you change your products, because it might be like some people don't tolerate any blood on their menstrual products, so as soon as it has any blood, they change it, or they're changing like a panty liner every 2 hours. But if you're changing like a real pad, a tampon every 2 hours or more, then that is like too much bleeding. And then the other kind of big sign to look for is passing blood clots that are large. And so sometimes teens or tweens have a hard time like with that concept. And so I'll usually say, like, do you have like chunks of blood that come out? Do you have solid blood that comes out? And if it's bigger than like an inch or a quarter or so, then that's a sign that you're having too much bleeding.
And they're like, what's a quarter?
I know, totally. I was just like the other day in clinic, I was like, have you ever seen money before?
Also, have you ever looked down into the toilet before? There's like two prerequisites to this line of questioning.
It's really hard. And even the changing products, when you ask, like, how often do you change products? They're like, I have no idea. And so I usually, in the school year, I'll say, can you get through a class period without changing products? And if they say no, that's like 45 minutes. That's too frequent. I think the other kind of big red flag to me is the nighttime waking. Yeah. The red flag.
There we go. Ding, ding, ding.
Because I think, go ahead.
What about menstrual cups? Not that a lot of kids use menstrual cups, but what's the advice around that?
That's a really good question. So, there's actually why these kind of like rules have come to exist is based on how we have defined heavy menstrual bleeding. And it really goes back to like some research studies that were like, heavy menstrual bleeding is more than 80 milliliters of blood per cycle. But with pads and tampons, that took researchers like getting pads and tampons from people and calculating how much blood loss. And so then there's some other tools that are...
And that's just under 3 tablespoons, just so people know.
Oh, thank you. Yes.
Right?
Yeah.
Okay.
And then there's another tool that's been developed called the pictorial bleeding assessment chart. And that is a chart that patients can fill out that says how many pads did I use and how soaked were they? How many tampons did I use? How soaked were they? How many clots did I pass? And then you get like a score from that says if it's over a certain score, then it's too much bleeding. But those were all based in like old period products, and now it's
belt and suspenders period products.
Are you there? God, it's me, Margaret. Period products.
100%. When the period blood was blue on TV.
Exactly. Yes. And so now it's being adapted to the menstrual cup or other more like recent products to be able to figure out like how much is too much. And the menstrual cup can hold, I always forget how much, but it's a lot of blood, like more, I can't remember exactly how much it is.
It's hard to overflow that thing.
Yeah. And so if you're changing that frequently, that's a lot of blood.
Do not pass go. Do not collect $200. Just go right to your doctor.
Yeah. Yep. Yeah.
So 7 days, more than 7 days of bleeding, can't get through 2 hours or a class period. Sleep is interrupted. What about pain, cramping, discomfort? Is that something that you're typically interested in? Is that something more that a gynecologist would be interested in? Talk us through that.
For pain and discomfort, usually I'll defer to the gynecologist. I sympathize and then say you should talk to the gynecologist. But it can be, we certainly have some data that people who have bleeding disorders will have more other symptoms of
Mhm.
period time. And so it is important to I ask those questions. The other thing is we often use non-steroidal anti-inflammatory drugs like ibuprofen, Aleve, things like that for period pain. And in a lot of the bleeding disorders that we take care of, we usually will say you can't use those medications because they can make your platelets not work as well. And so then we have to get creative about how are we going to manage your pain with your periods while you also have this bleeding disorder.
Side note, I was at a meeting of pediatricians last week, and there was a huge debate in the room about when it is okay to use non-steroidals, ibuprofen, so Advil, Motrin, naproxen, Aleve, all these medications. And it was very age divided. It was so interesting. And the older pediatricians, I was one of them, were very anti, right? Because we've always been taught that if you already have a bleeding disorder, you bleed more with those medicines. And actually, the younger pediatricians were less inclined to be nervous about those medications. So it's interesting that you're saying this because I tend to be very conservative about those medicines for pain relief, and instead would normally tell people who have bleeding disorders to use Tylenol for pain, right? Which some people think works just as well, and other people don't have that experience.
Yeah, and I think it depends on the bleeding disorder and what their other bleeding symptoms are. The nonsteroidal anti-inflammatory drugs can decrease menstrual bleeding, and so for some people, it might actually be so beneficial. So some of my patients' individual decision and say, "All right, let's watch your nosebleeds while you take your ibuprofen during your period and see how things go."
Which hole is the blood coming out of more? Yes, fascinating.
Is there, I know that, and correct me if I'm wrong, but hemophilia can be carried by females, but it is manifested in males. Is that correct or incorrect? Can females have hemophilia?
Yes. So big shift in the hematology world thinking, that forever people only thought that males could have hemophilia because the gene that makes the protein clotting factor 8 and 9 is on the X chromosome. And so a male would have an X and a Y, and so wouldn't have another X to balance out. But somebody with 2 X chromosomes could have another X chromosome that balances out the one that doesn't have the right or the correct form of the gene. But what we've learned over time is that people who carry the hemophilia gene could have decreased expression, or they could have decreased factor levels, and so will have hemophilia. And then we also know that even if your factor levels are totally normal, but you carry the hemophilia gene, you have more bleeding symptoms than somebody who doesn't carry that gene. And we don't know exactly why that is, but certainly people who carry the gene for hemophilia can have bleeding symptoms.
And how does that impact menstrual bleeding as opposed to other injuries that might affect a hemophiliac?
It tends to be that menstrual bleeding is the thing that brings patients to attention to see the hematologist. I always think it's a monthly or more challenge to your hemostatic system or your clotting system. And so maybe it's not that you have other times of bleeding. It's just this happens so often that it draws people's attention. It also, during stress, sometimes our bodies will increase von Willebrand factor levels. So sometimes that kind of counteracts another deficiency. So that might be why people don't present. But heavy menstrual bleeding can be the sign that brings somebody to attention.
And then we'd be remiss if we didn't start talking about iron a little bit and anemia. So maybe we can land this conversation there, but let's get into it for a few minutes. So can you help people understand what is meant by the term anemia and why? Let's connect some dots for people in the most basic way, and then we'll talk about preventing it and how we use iron.
Inside your red blood cells, there's a protein called hemoglobin. To make hemoglobin, you need iron. You also need proteins that make the hemoglobin structure. When your hemoglobin is below the age-defined normal values, and it's different depending upon what age you are, when it's below that normal, that's anemia. So there's lots of different things that can cause anemia, like red cell breakdown problems, hemoglobin production problems, but the most common cause is iron deficiency, so not having enough of that ingredient. I like to think about it as our iron economy. So you take in iron from the food that you eat. You get like 1 or 2 milligrams of iron a day, just like in whatever you might eat, but you have to eat food that has iron in it. So if you're like, I only ate this banana and that's all I ate all day, you did not get any iron. So you get iron in through your diet, and then you use that iron, and then you lose a little bit. And we lose some in like sweating, we lose some in skin cell sloughing as it gets removed. And you're kind of kept in this really tight balance. When you're having normal, not heavy periods, you lose another milligram of iron during that time. When you're having heavy periods, you can lose up to 4 to 5 milligrams of iron. So very easily, you get into a quick deficit of not having enough iron. And initially, your body says, okay, I have all this iron in my storage molecule, and that storage molecule is called ferritin. And so we keep it like in our ferritin. We have it on backup, it's in reserve, but you work your way through that ferritin, and then eventually you don't have enough of your iron to make hemoglobin and you become anemic. Historically, people didn't treat iron deficiency until you became anemic. You had to like be at the depths of iron before you could get treatment. But now we know that being iron deficient, even without anemia, can affect all different parts of your body. So can affect your thinking, it can affect muscle development, emotions, school performance, all these other things. And so even if you're not anemic, it's really important to get treated for your iron deficiency.
And how do you do that? Like, what are the treatments beside? Because our pediatrician was always like, just more red meat. And I was like, but I thought I was giving them too much red meat. And they're like, no, just
more so let's start
meat.
with nutrition maybe as the first pass.
Yeah. I think so. If you're iron deficient, even eating all the steaks in the world will not correct a deficiency. It'll help like think about what can I do about my nutrition to help prevent future iron deficiency, but really you're going to need iron supplementation to get your deficiency corrected. But I do think when I talk to teens and tweens about what they're eating, it's always a really hard conversation. I'm like, do you eat breakfast? No. Do you eat lunch? Sometimes. What do you have for lunch? Chips. Okay. What do you eat for dinner? Like, do you eat as a family? Do you eat in your like friend group? How do you like have dinner? And then they're like, well, sometimes, I'm running from my afternoon club to my evening sport. And so we usually just like pick something up on the way. And they're like, do you eat a snack? No. I'm like, oh my goodness, you just don't quite have enough in your diet to keep up with like all the things you need to do in your body. And so sometimes it's just like thinking about like oatmeal has some iron in it. Beans have iron in it. I feel like there's a lot of people who are vegetarian or vegan. So what can we think about that could help you increase iron in your diet? And so like, I'm like, potato skins. Can you eat, like, if you're going to eat a big potato, eat the skins, anything to try to like review what else could they eat to get iron.
The darker, leafier greens, like the darker the green, the more iron that's in there. It's another good hack. Milk is iron fortified. Most milk is iron fortified. And grains, a lot of grains are iron fortified. And looking for that on the label actually makes a big difference because these are really good sources. Cooking in a cast iron pan is like the best hack of all time because it really does pull iron into the foods that are being cooked in the cast iron pan. But, as you said, this is not about getting back from a deficiency. This is about maintenance. We need iron on an ongoing basis. How about medical interventions? When should someone take iron? And I'm just going to go there and say, anyone who's ever taken iron knows that the biggest complaint about it is the constipation that iron supplementation causes. So when should someone take it? And, how do you balance that downside, which happens for so many people?
Yeah, I think ideally, maybe as I'm biased as a hematologist, I like to start iron once I know I have labs that show that you're iron deficient. So I think if you're a teen or a tween, or you're a parent or an adult, a responsible adult for a teen or a tween, if they're like, I always say if they have the blahs, which is always so hard when you're at this age period, but there's so many reasons to feel blah. But if you're like, they sleep all the time and they still don't have enough energy, they're complaining of feeling dizzy or lightheaded, headaches, maybe their like baseline anxiety is a little bit worse than they normally are, and you've done all the things that have tried to address them. I think then getting to your pediatrician and saying, we're wondering about iron deficiency, and then the labs you need are a CBC and a ferritin at the minimum. If you're found to be iron deficient, there's a bunch of different oral iron supplements, like a million of them. Iron is always complex to a sugar, so like ferrous sulfate or ferrous gluconate or ferrous find a sugar. And I always say whatever one you'll tolerate is the one you should take. And it tends to be, if you can start taking it, that the kind of GI kind of upset stomach will get better with time. So sometimes it's just like pushing through. Sometimes taking it with food is better. Some people do it better without food. So trying different times. And then there's some data about either taking it daily or every other day. Some people absorb it better taking it daily. Some people absorb it better taking it every other day. If you're having lots of GI side effects, sometimes taking it every other day will decrease those side effects, and then you might tolerate it better.
I love that you started with, we really want to know that your iron level is low, because this is a good example of something that in most people, it's benign. If you take extra iron, it's fine. But there are people who have too much iron. There are people whose bodies do not clear iron, and they deposit that iron in different parts of their body, and they may not know that they have that. And so for those people, adding extra iron is not just, not necessary. It can actually cause issues. So, like everything else, it's not one to just go buy whatever supplement du jour and take the thing, right? This is something to do with a little bit of guidance. And then one last little general pediatrician hack that we used to teach parents. I'm doing this for the YouTube viewers. I'm pulling down my lower eyelid and showing what's called my conjunctiva, which is the inside of my lower lash line. And if that area looks really pale, that can be a sign of anemia, which is hard to tell if you've never looked at that part of the body before. But if you're looking for an objective criteria, you might want to just flip your lower lid.
Or if you're somebody who has periods and you're having periods longer than 7 days, you're changing more than every 2 hours, you're passing large clots, those are like over probably 50% of people with heavy periods will be iron deficient. So that is like in and of itself a reason to get screened.
And Kristina, that gets at the question, the intersection of so many aspects of caring for kids this age, because it's like they have the blahs, they don't want to get out of bed, they're low energy, their mood is off. It's like, how do I know what it is? And sometimes it's process of elimination and asking questions to the kids. And what I love about your guidance is that you totally get how to ask questions of kids in a way that they can understand what you're asking. You understand their reality. You don't judge their reality. You're trying to get at the source of their situation by putting yourself in their shoes, in their world. So for those of us adults who look at our kids and think, oh, Christ, like, could you please eat a proper lunch, or like, get out of bed and let's go, we're going to be late. If you take a page out of Kristina's book and step back and think, I'm buying a lot of pads, or I'm buying a lot of tampons, or the laundry looks like a bloodbath, or like, it's hard sometimes to step out of the day-to-day irritation of caring for kids when things aren't going smoothly. And I think your advice is so great, is like, we have to actually pay a little attention and start to track some of this stuff. And as Cara said earlier, like, not blow it off, but really, if we're wondering, go see our pediatrician, get a referral to a specialist like Kristina, because there could be really important underlying information about our kids' health and maybe even our health that we don't know.
Kristina, did you catch where Vanessa said bloodbath in there?
Yeah.
Thank you. I was waiting for somebody to notice that. I almost said a homicide scene, but I felt like that was like a little
duly clocked. Oh, that would have been amazing. That would have been amazing. Kristina, what a pleasure to speak with you. Thank you for breaking this down. Thank you for helping people to understand where to begin the thinking. We aim to be an alternative to searching out your own medical information online because the answers are complicated and scary sometimes, and frankly, sometimes they're downright wrong. And you made this topic, which is to me complicated and scary, very clear and very straightforward. And it's so appreciated.
But there is one place we know we can link to, which is the Foundation for Blood Disorders in Girls and Women, because it is science-based, research-backed information. Kristina works closely with them. Don't just do a random search. We will link in our show notes to the foundation's site and to Kristina's work so that you have a trusted place to go. Kristina, thank you so much for being here.
Thank you so much. I could talk about periods all day long.
So can we.
So fun.
Kindred spirit, Kristina. Thank you so much for listening. You can email us with questions, feedback, or episode requests at podcast@lessawkward.com.
If you want to learn more about what we do to make this whole stage of life less awkward for everyone involved, our parent membership, our school health ed curriculum, our keynote talks, and more are all at lessawkward.com.
And if you want products that make puberty so much more comfortable, visit myumla.com.